Good morning. As we know, cancer is the second commonest cause of mortality worldwide after the cardiovascular diseases. And the usually worldwide cancer incidence about 18 million, and out of the 18 million, 9 million people die of the cancer. So such a great burden. And among the mortality, lung cancer has the highest mortality among all the cancers. As we see in India, about 67,000 patients are diagnosed of lung cancer every year. Out of the 67,000, 63,000 die per year. And in the COVID era, we treat the lung cancer patients for 6 weeks of treatment with definitive chemo radiotherapy. But we have brought it down to the 4 weeks with giving the same doses and almost trying to give the same overall survival and effect, or maybe better. So 6 weeks of treatment has been brought down to 4 weeks. And this is very useful in the COVID era because the patient has to come 6 weeks versus only 4 weeks during the treatment, because patient usually come daily for the radiation therapy. Now I invite Dr. Sushma Agarwal to present the data. Thank you.
Thank you, sir. Good morning. As Dr. Rastogi has already briefed, the worldwide incidence of cancer in men, we can see that lung cancer is the commonest. And if we see the data of women, then breast cancer is the commonest cancer. Now coming to the Indian data, which has been given by Globocan in 2018, we can see that for both sexes, lung cancer comes fourth. But if we look at the incidence in men, lung cancer is second commonest cancer in men in India, which is second to head and neck cancer. But apart from this, the mortality is the highest due to lung cancer. Now let's see the stages in which they present in India. The data from Tata Memorial Hospital shows that only 1/4 are early stage and 40% are locally advanced and 30% are metastatic. On the contrary, when we looked at our data, which we published in 2013, we found that only 10% are locally advanced. We hardly ever get to see an early case, and 90% are metastatic. Now, why do they present in such an advanced stage? This publication from PGI Chandigarh showed that the symptoms and the radiological features, they confound with the chronic and acute infectious diseases, which we all know very well. We live in a country of tuberculosis. And there is underreporting of symptoms. There is delayed recognition of ominous signs. And in the periphery, there is lack of advanced diagnostic facilities. Now, briefly about what is early and what is locally advanced. It's dependent upon the size of the tumor, and tumors which are about 3 centimeters are T1, 3 to 6 are T2, and they usually do not involve the adjacent structures. They are far from the carina, and they would be having only hilar lymph node involvement, which is called N1. So these are very rare in India. Now coming to the advanced, which is the topic of presentation today, locally advanced is a spectrum of T3s, T4s, and N2 and N3. So T3s are bigger than 6. T4s usually involve the chest wall and the mediastinum. The involvement of ipsilateral mediastinal lymph node is called as N2, and that of contralateral is called as N3. So this locally advanced, the spectrum of resectable. Potentially resectable are those in which we give upfront either chemo or radiotherapy and then resected, and unresectable are far too gone for any kind of surgery. Now the brief workup, the most important parts are that apart from CT scan, PET CT is mandatory if we have it, because it tells us about the positivity of mediastinal lymph nodes, which has a bearing on the surgical resectability. So if the lymph nodes are negatives, they are good candidates for surgery if it's a peripheral tumor, and if it's a central tumor, and even if it is mediastinal lymph node is negative, they are likely to have positivity. So an EBUS is done to confirm the negativity or positivity of the mediastinum and then take them for surgery. While if you pick up a mediastinal lymph node on PET-CT, then a confirmation by histology is ideal, and if it is positive, then they are usually should be taken up for a multimodality treatment rather than a single modality of surgery. A brief about the management of early stage. They are for surgery, but these patients are usually elderly, they are smokers, they have a bad lung. More often than not, they turn out to be unsuitable for surgery. So these patients are for a focused kind of radiotherapy, which is called stereotactic radiotherapy. Coming to the advanced cases, as I said earlier, the N0s and N1s are the ones for surgery. The moment they become N2, they have to go to a multidisciplinary team, and they have to undergo a prior therapy and then see whether they become resectable. The unresectable go for chemoradiotherapy, which I shall be discussing now and is the topic of discussion today. Apart from the stage, the histology has a major role in the outcome of locally advanced. So squamous has a higher rate of locorenal relapse, and adenos have higher distant relapse. Apart from them, they are usually elderly, they have comorbidities, the performance status may not be good, their lung is usually bad, the PFTs may be poor, and all this has a bearing on the compliance to treatment. To top this difficulty, upstaging with PET-CT is so common that about 50% of the patients get upstaged by PET-CT. So what are the kinds of chemoradiation? One is sequential, the other is concurrent. And in sequential, the chemotherapy upfront 4 cycles is followed by the sequence of radiotherapy. And in concurrent, there is no upfront chemotherapy. The chemotherapy is given along with radiotherapy. Now, what is the rationale for sequential or concurrent? So we usually get such big tumors, which you can see on CT scan, and to treat such tumors by radiotherapy, we will have to give such big fields which will irradiate the whole of mediastinum and one lung. So if we give upfront chemotherapy, then as you can see in this image, the tumor was so big when the patient came to us. With chemotherapy, it becomes smaller in the right side CT images. And so therefore, this results in tailoring of the radiotherapy portals. And so because of this, the normal lung, the esophagus, the spinal cord can be avoided in the radiotherapy fields, and thus this has a bearing on the toxicity. Apart from this, the associated atelectasis may also resolve, and it also helps in giving radiotherapy. The disadvantage is that there may be a delay in starting radiotherapy, and this disadvantage is not there in concurrent. The radiotherapy starts immediately, and concurrent chemotherapy gives a double kill phenomena. It adds to the tumoricidal effect of radiotherapy, but then this is at a cost of higher toxicity in case of pneumonitis, like pneumonitis and esophagitis. Now let's see what to practice. A meta-analysis of all the randomized studies showed that there was a 5% gain in survival with concurrent chemoradiotherapy. This is upper yellow line, which shows that it is superior to sequential. But in a country like ours, The other challenges are that patients often present with weight loss. We are a low BMI country, and so therefore there are compliance issues because of this. Our patients usually present with very advanced stage. To talk to this problem, the low socioeconomic status and the lack of health insurance policy in our country. So there are certain guidelines for countries with limited resource settings, and they say that it is best to give sequential chemoradiotherapy because if you give concurrent, though there is survival benefit, but then we should be able to manage the toxicity and not end in mortality. So our journey of chemoradiation in locally advanced lung cancer, when we started in 2007 to 11, we gave concurrent to the fit patients and sequential to the non-fit. And what we observed on our audit was that the morbidity was double that of sequential in concurrent. As compared to 20% in sequential, it was 40%. And the distant relapse rate was surprisingly higher with sequential. The median survival was same in both the arms, it was 12 months. So therefore, since sequential was safe, we practiced it from 2012 to 2018. But then we thought that should we do something to improve the dismal outcome? And therefore, we embarked on doing a pilot study, a feasibility study of hypofractionated radiotherapy. So what is hypofractionated radiotherapy? If you see the upper bar, the conventional radiotherapy we give at 2 gray per fraction, which is over a span of 6 weeks, which amounts to a biological dose of 72 gray. And if we give a hypo, the dose per fraction increases to 3 gray, and the treatment time is shortened to 4 weeks, which results in an increase of the biological dose to 78 gray. And this is based on the evidence from the 7 randomized American studies, which showed that higher biological dose has a bearing on improving outcomes in terms of survival and decreased loco-regional failure rates. This is also important in a country like ours, which has resource constraints and high patient load and a long waiting list. And today, in COVID times, we want that the patient should be exposed to the hospital for a shorter duration. So briefly, what is the process of radiotherapy when the patient comes to us after a workup? A CT scan thorax is done to capture the tumor data, and then we draw the target on the CT scan along with the lymph nodes, and then the soft data is taken up for treatment planning with the aim of covering the tumor properly and avoiding the normal structures as much as possible, like lung, esophagus, and spinal cord. And then the patient is taken for treatment delivery in a linear accelerator. Now, the challenges with radiation in lung are, as you can see in this image, that the tumor is moving, and so therefore, if we plan for a tumor, then it should be covered well and it should not move out of the field. So what to do? So then for this, we do a 4D CT scan, which shows that there is a marker on the patient's chest. And this is the infrared camera, which captures the motion of the chest. And this is coupled with the 3D data of the patient. And as you can see in this dial, that the respiratory cycle is captured. So what we get is this, that is a 4D data set. Now this 4D data set, if we can decide whether we want to break up the respiratory cycle into 10 or 4 divisions, and then we draw the tumor in each data set. And as you can see that in the 0 data set, the red is the target volume, which is empty, which is black on one side, and then that part is covered in the 40% phase. So the image below this shows that the blue is the tumor in various phases, And the yellow line is the amalgam of all the phases to capture the tumor in all its motion. Also, as you can see that in a conventional where we don't have a 4D data set, we would give a margin around this GTV for motion of the tumor to the tune of about 1.5 centimeters craniocaudal direction. But if we do a 4D data set, then our tumor volume turns out to be smaller, and so therefore we can have less of side effects in planning. And now coming to the final part, which is image guidance in radiotherapy. So what is image guidance? So it's very important to ensure that what we plan needs to be delivered. So how to ensure that? So for that, the linear accelerator is equipped with either an X-ray or a CT scan facility, which as you can see on the wings, which are on the side. So that CT scan is taken immediately prior to radiotherapy, and if you have resources at the end of radiotherapy to confirm that what you planned was that you delivered. Now I'll be showing you a video in which you can see that the purple line covers the tumor and the blue line is the margin for motion and setup errors, and this video shows the tumor motion over a period of 4 weeks, and it should not go out of the blue line. So as you can see that the over 4 weeks, it never moved out of the blue line. So this is how image guidance helps us. Now coming to the last challenge of delivery of radiotherapy in lung cancers, as you can see that there is a mediastinal shift because of the tumor. So if we plan the fields are towards the periphery of the thorax, and as time progresses, maybe by second week, third week, the tumor regresses, the mediastinal shift is corrected, and had we been treating in the periphery of the thorax, we would have missed the tumor. So here comes the importance of image guidance. Now I invite Dr. Joe Jose to present the outcome of the pilot study and compare the data with the audit data.
Well, good morning. I'm going to be talking to everyone about the outcome of hypofractionated sequential chemoradiotherapy in locally advanced non-small cell lung cancers. So the aim of this study was to estimate tumor response, progression-free survival, and overall survival. And we also looked at the incidence of toxicities arising from radiotherapy, that is esophagitis and pneumonitis. And we compared this prospective data with retrospective data of patients treated in our department with conventional radiotherapy. So when we selected patients for hypofractionated RT, we looked at certain eligibility criteria. They had to be pathologically proven patients of locally advanced non-small cell lung cancer. The stages, they had to be either of stage 3A, 3B, or 3C, as per the 8th edition of AGCC. They had to be proven non-metastatic by PET-CT, and the treated volume, that is the planning target volume, had to be less than or equal to 700 cc. And coming to performance, the patient had to have a performance score of equal to or greater than 70, and the FEV1 required to be greater than 1 liter for the patient to be taken in. And of course, the patient had to have normal blood parameters. So the first step in the radiotherapy process, as was already discussed, was a 4D CT scan. Now, when we took the scan, we made sure that the patient was immobilized and positioned, and this positioning would be replicated throughout the entire treatment process. So as you can see in the picture there, the patient is holding a thoracic wing board, which helps immobilize his arms. And we also have a device called a backlock. It essentially molds itself according to the contour of the patient so that the patient is positioned in one exact position. So step 2 is delineating the tumor. Now we've got all our 4D CT imaging data, and step by step in all the respiratory cycles, we draw out the tumor. And as you can see, once we've drawn out the tumor, we combine all these delineations and we put it into one single delineation. As you can see over here from the overlapping lines, that all the delineations have been combined together. So the next step would be the planning process, right? So now we've drawn out the tumor and we applied a mark. You can see that over here, that's called the total gross target volume, which is the tumor itself throughout all the phases of respiration. Now, once we've done that, we go on to the second step, which is to give it a margin. So we give it a margin over here, and that's called the planning target volume. So the volume encompassing this margin around the tumor is actually the treated volume. And basically, we give this margin to take care of errors that might creep in while positioning the patient during daily treatment. Now, the second most important and vital point in the planning process is to make sure that the tumor is adequately covered. So as you can see in this image here, we have the tumor over here, and this blue coloring indicates the radiation dose. And as you can see in this particular image, the tumor is adequately covered. But it's not only enough to make sure the tumor is adequately covered. We have to make sure that the surrounding normal structures are not irradiated, because that would result in toxicities, which is what we don't want. So we give certain constraints, volume-based constraints to the important structures around. As you can see, the lung, we've given a constraint. And in this image, the opposite lung is spared, and a majority of the involved lung is also spared. So we hope to meet that constraint. In this particular image, you can see the esophagus, which is out of the radiation dose field. So we hope to save these esophagus-related toxicities from arising. The spinal cord is also completely out of the radiation field. So in this way, we have planned the irradiation process by making sure the tumor gets adequate dose and by preventing side effects to the remaining normal structures. So now the next step, of course, is image-guided radiotherapy. And that is done primarily with a device called a cone beam CT, which is integrated into the linear accelerator. It is a part of the linear accelerator. And so we lay the patient down. Before treatment, we take a CT scan with this cone beam CT, and we get this image, right? And now once you've got that image, we take this image and fuse it with the prior 4D CT scan we took earlier on. And that is this image. So once these two images are fused, we then look at what all errors have crept into positioning the patient. And as you can see, this is of importance. I'll show you in this graph over here that we look at errors in the X, Y, and Z axis, and this is in millimeters. And you can see that on this is over the treatment duration of one patient, over 20 days. And you can see that there were significant errors when the patient was initially set up of 10 millimeter in the Z axis, the X and the Y axis during various days of treatment. So these errors were then corrected before treatment by moving the patient position to ensure that radiation was accurately delivered to the tumor. So in this particular study, 39 patients of seemingly locally advanced lung cancer patients came to us in the OPD, and all these 39 patients underwent PET-CT, and out of which 22 were found to be metastatic. The remaining 17 patients were administered neoadjuvant chemotherapy, and 2 patients were subsequently excluded from the study for having progressive disease. And then the remaining 15 patients were subjected to hypofractionated radiotherapy, out of which 14 patients completed the entire treatment. So now we took this data from the hypofractionated study and we compared it with retrospective data of the patients treated in our department, the locally advanced non-small cell lung cancer patients treated in our department between 2006 to 2018. We compared both these arms with regard to toxicity, response rate, PFS, and OS. So as you can see, this is the comparison of the patient characteristics of both arms. You have the conventional arm, which is a retrospective arm, the hypofractionated arm, which is a prospective arm. And as you can see over here, the major differences, they arise in the fact that in the conventional arm, you can see that majority of the cases are of the 3B stage, whereas in the hypofractionated arm, you can see that majority of the cases are of the 3C stage. And the reason for that being that back then when we were giving conventional radiotherapy, PET-CT was not available. So in our current sort of protocol, we're using PET-CT for all the patients. So a lot of these patients are being upstaged from stage 3B to stage 3C. Apart from that, you can also see that the other characteristics seem to match up between both arms. So now coming to the type of treatment, with regard to the conventional retrospective arm, we had 46% of the patients receiving sequential CTRT and 54% of the patients receiving concurrent CTRT. And in the hypofractionated arm, as we all know, all the patients received sequential CTRT. Now coming to the dose of RT, when you look at conventional, which is at 2 gray per fraction, 25% of the patients received doses from anywhere between 45 to 59 gray, and 75% of the patients received doses from 60 to 66 gray. And in the hypofractionated arm, all patients received 60 gray at 3 gray per fraction. So the first thing that we talked about was evaluating toxicities, and we did this using the RTOG toxicity grading system. And with regards to lung toxicities, we like to focus on grade 3 and grade 4. So grade 3 is severe symptomatic fibrosis or pneumonitis with dense radiographic changes, and grade 4 would be when you have severe respiratory compromise with the need for assisted ventilation and continuous oxygen supply. And when it comes to grade 3 and 4 esophagitis, we can see that it's grade 3 severe fibrosis, the ability to only swallow liquids. And when it comes to grade 4, it involves dire consequences like necrosis, perforation, and fistula formation. So this is the image of radiation-induced pneumonitis, where you can see that the borders of pneumonitis are matching with that of the radiation field, which is a classical sort of look there. So when it came to compliance, you can see that grade 3 and 4 pneumonitis matched up in both arms, and grade 3 and 4 esophagitis was slightly more in the conventional arm, and the mortality rates were also similar in both the arms. So like I said before, when we come to the post-RT pneumonitis, the severe grades of pneumonitis were similar in both arms. Grade 3 and grade 4 were similar in the hypofractionated as well as the conventional arm. Now, when you look at the factors causing pneumonitis, we basically saw this, that if a larger volume of the normal lung was irradiated, was getting a higher dose, that would lead to severe grades of pneumonitis. And when we evaluated the patients who developed severe grades of pneumonitis, we noticed that they had a low pre-RT FEV1, and in the conventional arm, we noticed that they had a low pre-RT FEV1, and that concurrent CT, wherever it was given, it led to higher rates of severe pneumonitis. When you come to the hypofractionated arm, we noticed that lower lobe tumors, because lower lobe tumors have higher degrees of motion throughout respiration, they had a higher chance of developing adverse pneumonitis. Elderly patients greater than the age of 65, once again, low pre-RT FEV1 was a contributing factor. And of course, a large tumor would automatically mean that a larger volume of normal lung would get involved. So that also led to dire pneumonitis. And when we come to post-RT esophagitis, it was around 13% in the hypofractionated arm and 17% in the conventional arm. So looking at the factors causing esophagitis in the conventional arm, we can see that concurrent chemotherapy, just like for pneumonitis, concurrent chemotherapy played spoil sport here and led to grade 3 and 4 esophagitis. And of course, a large tumor with proximity to the esophagus would automatically mean that the esophagus is getting higher dose and a higher chance for developing esophagitis. And that same reason was also present in hypofractionated RT. And apart from that, we also noticed that the longer the length of the esophagus involved, the higher the chances were for involvement of for getting dire esophagitis. So as you can see over here, this particular image, a large segment, a large length of the esophagus is involved in the treated dose field, and that has led to, in this particular patient, a severe grade 3 or grade 4 esophagitis. So now, once we look at the toxicities, we assessed response after treatment, and response is assessed 3 months following treatment with the PET-CT, and it was classified as per the RECIST criteria, which showed that it's divided up response into complete response, which is complete disappearance of the tumor, partial response if there's greater than 30% decrease in the dimension of the tumor, progressive disease where there's a greater than 20% increase in the dimension of the tumor, and stable disease which lies between partial and progressive disease. So when we come to the response assessment, we looked at a term called clinical benefit ratio, which is the addition of the percentages of complete response, PR, and stable disease. So when we look at the conventional arm, we can see that there are higher number of stable disease patients and progressive disease patients, which led to a clinical benefit rate of 83%, which is lesser than the hypofractionated arm, which had higher percentages of partial responses and complete responses, and it had a CBR of 91%. So we also did response assessment by PET-CT in all patients in hyperfractional RT, and there's a mean fall in SUV max by 53%. So coming to the overall results of this study, we can see that in the hypofractured arm, which is the patients that were treated recently between 2018 to 2020, when we compare it with the conventional retrospective arm, which is patients treated from 2006 to 2018, we noticed, like I mentioned before, that CBR was 91.6% in the hypo arm and 84% in the conventional arm. When we come to progression-free survival, the median progression-free survival was 18 months in the hypo arm and 8 months in the conventional arm, which was found to be significant. And coming to the 1 year and 2 year PFS rates, it was 65% and 27% respectively in the hypo arm, and 40 and 15% respectively in the conventional arm. Coming to overall survival, the median OS was not reached in the hypo arm, and it was 13 months in the conventional arm. Coming to the 1 year and 2 year OS rates, it was 65 and 55% respectively in the hypo arm, and 55 and 15% respectively in the conventional arm. Now I'd like to hand over to Sushma ma'am to discuss the review of literature. Thank you.
So now coming to the review of literature, there are a few randomized studies who have compared the sequential and concurrent hypo-RT. The first is the European randomized study, which had accrued 158 patients, and they had used image guidance, and they found that the esophagitis rates were about 14%, slightly high than 5% in the sequential arm, and the pneumonitis rates was 18% with concurrent hypo-RT as compared to 14% with sequential hypo-RT. Now, in terms of survival, the progression-free survival rate was 10.8 in sequential and 8.5 in concurrent, and it was statistically non-significant. And similarly, for overall survival, the survivals were 16 months in both the arms. The other randomized study, which accrued 130 patients, which compared concurrent with sequential hypo-RT, they did not find any difference in the esophagitis or pneumonitis rates, and the 2-year survival was only slightly different between the two arms, 50% versus 46%, and the mortality they have reported as 3%. A very small randomized study from our country in AIIMS, New Delhi, on 36 patients, they compared sequential conventional RT with sequential chemo followed by concurrent hypo-RT. Their doses were a bit less as compared to the standard. Image guidance has not been mentioned, and they found that the esophagitis rates were surprisingly higher in the control arm, 16%, as compared to 8% in the study arm, and the pneumonitis rates were low in both the arms, 5% versus none in the concurrent. The progression-free survival was markedly different. It was 5.3 months in the control arm as compared to 17 months, a jump by more than 12 months, and the survival doubled from 12 months to 24 months. A very large Polish study by Dr. Kepka on 173 patients, which was a dose-finding study, and they compared a sequence of doses ranging from 57 to 61 gray, and their side effects were very less. Esophagitis was 7% and pneumonitis was 5%, and they had very good progression-free survivals of 25 months, and even the overall survival was best among all, which we have discussed till now. It was 38 months. And when we compare our small data with the above, we found that our esophagitis rate is 13%, and it compares with the data of the other studies. And even the pneumonitis rates of 13% is also comparable with the data discussed above. Our progression-free survival improved by 10 months, though it's a very small sample size. And it is also comparable to the above studies. And our overall survival, the median was not reached versus 13 months is also comparable, but our mortality seems to be slightly higher, 13% and 12% in the audit. So that is what it is. Now let's see what the data literature has to speak about the side effects in terms of pneumonitis. A very large database analysis of about 4,000 patients. This was an individual patient data meta-analysis, and they concluded by saying that the highest risk of pneumonitis was in patients more than 65 years, those receiving concurrent chemo, and the predictors of pneumonitis were a larger lung dose and the lower lobe tumors. And that is what we also found in our pilot study. And then they categorized the patients that if the V20, that means the volume of lung getting 20 gray, was higher than 25%, then they are at intermediate risk for pneumonitis. And in our patients, both the patients who got severe pneumonitis had a V20 of more than 45%. Now, comparing the literature with our data on esophagitis, the same group also analyzed the esophageal toxicity, and then they concluded by saying that if the volume of esophagus getting 60 gray was higher than, or if it fell between 1% to 17%, the patients are at intermediate risk for esophagitis. And if they get volume of 60 gray more than 17%, the risk of esophagitis is high. And we saw V57 because 57 is 95% of 60 gray, which is very near to 60 gray. So we also saw that those patients who got more than 20%, here it is 17%, those were the patients who had higher grade of esophagitis, and even one patient died because of esophagitis. And also additionally, we found that the length of esophagus, if it was more than 8 centimeters, those patients are prone for esophagitis. So what did we learn from this small study? Is it safe for our patients? Yes, we can use it in Indian patients who have low BMI and have often come to us with weight loss. But we need to perhaps select the patient. We need to streamline a little bit more so that we don't end up in mortality. And should we lower the dose constraints for lower lobe tumors, though it is desirable, but we wonder whether with it will it be possible. Perhaps if we use intensity modulated radiotherapy, we might achieve this, as well as be able to decrease the length of esophagus coming in the radiotherapy field. What were the challenges in accrual? If you see the number of patients of lung cancer registered in our department from 2006 to 2020, only 130 were locally advanced. And since the availability of PET, those locally advanced even get upstaged to the tune of 56% to metastatic disease. So I would like to conclude that hypo-RT appears to have better clinical response rates and perhaps survival as compared to conventional. Toxicity rates are also comparable to conventional. Our results are also comparable to the literature, and decrease in treatment time is beneficial for developing countries with resource constraints and high patient load. And short treatment is also desirable in present COVID times, where we want the patient exposure in our hospital for a lesser duration. I would like to acknowledge the Department of Pulmonology for contributing to this study, and also the Department of Nuclear Medicine for giving us earlier dates for PET CTs in our patients. And this is what we had to say. Thank you.